Welcome back. Let's continue our discussion about verbal de escalation by applying these skills to psychiatric emergencies. Now, let's apply these skills to psychiatric emergencies. Patients with schizophrenia, severe anxiety, or bipolar disorder can unfortunately have a psychiatric crisis. These calls can be complex because the patient's perception of reality may be altered. First, create as calm an environment as possible. If a patient is psychotic or highly anxious, loud noises and chaos worsen it. So, if you can, turn off lights and sirens on arrival, ask unnecessary people to give some space, while ensuring you have what help you need. Fewer stimuli can help someone settle. If the patient is hearing voices or is paranoid, too many responders crowding them can increase their fear. Have one provider take the lead in communicating, others hang back unless needed. Maintain extra personal space, as patients with paranoia might feel very threatened if you're too close. They may also have a fight or flight response if cornered, so keep that safe distance and open body language. When engaging a psychiatric patient, do not argue with their hallucinations or delusions. For instance, if a patient with schizophrenia says, "There are snakes all over me," you shouldn't bluntly say, "No, there are no snakes, you're hallucinating," as that can break trust or further agitate them. Instead, acknowledge how frightening that must be. You might say, "I understand you're seeing snakes and that's really scary. I don't see them, but I know you do, and I want to help you feel safe." This way, you neither confirm the delusion nor dismiss their experience. You focus on their feelings and safety. Similarly, if they believe something like, "Someone's out to hurt me," you can respond, "I'm sorry you're feeling unsafe. You're safe with us. We're here to protect you." Use a lot of reassurance. Reassure them that they are safe and you are there to help. Repeating phrases like, "You're safe right now, I'm here with you," can ground someone in extreme panic or dissociation. Also, if the person's in a manic or extremely agitated state, give clear, simple directions or choices, but only if necessary. Too many questions or complex statements can overwhelm someone in crisis. For example, instead of, "Can you allow us to check your blood pressure and maybe consider going with us to the hospital because we think you might need some help due to your condition?" Simplify it. "I'd like to check your blood pressure, okay?" One step at a time, gently phrased as a request. Leverage any rapport. If a family member or friend whom the patient trusts is on scene and calm, sometimes having that person speak gently to them can help. But be cautious. If family dynamics are part of the problem, like in a psych emergency where the patient is upset with family, keep them at a distance. Each situation is unique, but the principles remain: lower the stimulation, validate feelings, not delusions, don't argue, move slowly, and reassure often. The goal is to reduce the patient's fear and confusion so we can get them the medical help they need without a fight. Intoxicated patients, whether drunk on alcohol or high on drugs, present their own challenges for de escalation. Expect unpredictability. Substances can make people emotionally labile, one moment tearful, next moment aggressive, and can impair their understanding. Realize that a person who is very inebriated or on stimulants may not process information normally, so we have to adjust our approach. Keep your communication very simple. Use short, clear sentences and basic words. Instead of saying, "Sir, given that you've sustained trauma and appear to be inebriated, it's imperative we transport you," you'd simplify to something like, "You hurt your head. We need to take you to the hospital to check it. We're here to help you." Give one piece of information at a time. An intoxicated person might be easily confused or have memory lapses. You might need to repeat yourself calmly multiple times. That's okay. Be patient and prepared to repeat instructions or reassurances. For example, someone very drunk might keep asking, "What happened?" And you might have to answer repeatedly, each time with the same calm tone. Safety is a big concern here because intoxication, especially certain drugs like methamphetamine, PCP, or even a bad alcohol drunk, can lead to sudden aggression. Keep a safe distance and stance in case the person lashes out. Use the person's friends if they're calm to help if possible. Sometimes a buddy can convince them to cooperate. "Hey man," let them check you out. But be careful. Sometimes friends are also intoxicated and can either help or make it worse. It's important to set gentle limits on unacceptable behavior. For example, if an intoxicated patient starts to get physically aggressive, say they try to swing an arm or continually get up and stumble, you should calmly but firmly set expectations. "I know you're upset, but I need you to sit down. I don't want you to get hurt. Please don't swing at me." Use a firm, caring tone. It's a balance. You are not ordering them like an officer, but you are also establishing boundaries. Sometimes stating the obvious helps. "We're here to help, but we can't continue if you try to hit me." This lets them know their behavior has consequences. You might pause treatment or call more help. However, avoid any threatening language. Don't say, "If you do that again, I'll," except relating to getting police, which you might mention carefully if needed. Often with intoxicated individuals, calm repetition and simple reasoning can eventually get through or at least wear them down to compliance. For instance, "Mike, sit down for me, okay? I know you want to walk, but you fell and I don't want you to fall again. Sit down for just a minute, then we'll get you up with us. You might have to say this several times. Also, be aware of possible medical causes behind combative intoxicated behavior, low blood sugar, head injury, etc. While not exactly de escalation, it's part of scene management. Sometimes what looks like drunken aggression is a diabetic emergency, so keep that in mind as you calmly talk. Your partner might be checking vital signs or glucose in the background if possible. To sum up, with intoxicated patients, keep it simple, keep it calm, set clear boundaries, and pack plenty of patience. And as always, ensure you have backup or an escape plan if their behavior turns truly violent. Verbal techniques sometimes fail if the substance effect is too strong, and then it may become a situation for physical restraint or law enforcement. Domestic scenes, for example, a call to a private home where family members are in conflict or there's been a domestic violence situation, are among the most volatile we face. De escalation here means not only calming the patient, but possibly calming family members or bystanders and keeping yourself safe in a potentially charged environment. First, assess the scene as you approach. Are people actively yelling or physically fighting? If a fight is in progress, your best move is often to wait for law enforcement unless someone's life absolutely depends on immediate intervention. It's tough, but rushing into an active domestic fight can make you a target. If the scene is secure enough to enter, or once police separate the parties, your role is to provide medical care and calm things down around that care. One key tactic: separate and soothe. If two people are arguing, say a husband and wife or a parent and adult child, and it's safe to do so, try to get them into different areas so they're not triggering each other. For instance, you might ask one, "Could you step over here with my partner so we can check you out while I talk to X?" Effectively separating them. Then you can individually use your de escalation talk on each person. Often focusing on the one who is injured or in need of care is priority, and you might ask the other to give you space to help. "I know you're worried, but I need a little room to take care of them. Why don't you take a few deep breaths in the other room while we check them?" This can gently move an agitated family member away. When speaking to family members or a combative spouse, maintain a neutral stance. Do not take sides or cast blame. It's not our job to determine fault in an altercation, and doing so will backfire. If one says, "He hit me for no reason," and the other is saying, "She started it," avoid getting into the middle of that argument. Instead, focus on what you need to do medically. "Right now, I just want to make sure everyone is okay and not seriously hurt." Show equal concern for both if both are injured or upset. Use names if you know them. "John, I understand you're angry. I'm going to check Mary because she's bleeding, and I promise we'll address your concerns as well." To the other, "Mary, let's look at that cut." "John is upset. I'll have my partner talk with him over there while I help you." The idea is to diffuse by shifting focus to the medical problem and separating the disputants. If bystanders like relatives or children are crying or shouting, try to kindly enlist someone calm to take them to another room or simply speak in a calming tone, asking for a little quiet so you can work. Sometimes people follow that lead. Always remember, domestic scenes can flare up without warning. The person who is calm can suddenly become aggressive again. Keep one eye on the dynamics even as you treat the patient. If voices start to rise or someone moves aggressively, you may have to pause treatment and ensure your safety or call out for law enforcement if not already there. It's wise to have police present for domestic violence calls. If they aren't, consider requesting them as soon as you suspect a volatile domestic situation. You might say to dispatch, out of earshot, that you need police for scene security. Your safety protocol, like standing near a door and having an escape route, is vital here because domestic disputes can redirect toward you or your partner. In summary, de escalation in domestic incidents means calming each individual by separating them, speaking with empathy and neutrality, and keeping the scene focused on care. Be the stabilizing presence amid the chaos. And if things start getting out of hand, don't hesitate to get out and wait for backup. Your safety comes first. Another challenging scenario is dealing with sexually aggressive patients. For example, a patient who is making lewd comments, inappropriate touching, or advances toward an EMS provider. This can happen, especially if a patient is intoxicated or has an altered mental status, but sometimes even alert patients might act this way. It's important to protect yourself and maintain professionalism. Firstly, never be alone with a patient who has shown sexually aggressive behavior. Ensure you have a partner or another responder, maybe a firefighter or police officer, with you at all times in these cases. This is for both witnessing and your safety. If you anticipate a potentially inappropriate patient, say based on dispatch info or past encounters, plan ahead so a male-female team is present if possible, or at least two providers. Set clear boundaries if a patient crosses the line. You can do this politely but firmly. For example, if a patient makes a sexual comment, You might say in a calm, matter of fact tone, "Please keep your comments respectful. I'm a medical professional here to help you." If they try to touch you inappropriately, you should definitely speak up. Do not do that. That is not okay. It can feel awkward to confront, but it's necessary. Sometimes a firm verbal redirection will stop the behavior. Maintain a professional demeanor, no joking along or responding with anger. The key is to make it clear the behavior is unacceptable while still providing care. You might also subtly reposition yourself physically out of their reach if possible, while still doing your job. Keep your communication strictly professional and focused on care. Use a serious tone. For instance, if a patient makes a crude joke like, "Hey, beautiful, why don't we skip the hospital and go somewhere else?" You might respond, "I'm here to take care of your medical needs. Let's concentrate on getting you treated." Sometimes not engaging beyond a brief, firm response causes them to give up when they see you're not reacting or indulging. However, if the behavior continues or escalates, like physical groping, it may become an assault situation. You can involve law enforcement if you haven't already. In many regions, assault on an EMS provider is a crime, and that includes inappropriate sexual contact. Do not feel you have to tolerate it. After the call, document the encounter thoroughly and report it according to your agency's policy. Note exactly what the patient said or did and how you responded and who else was present. Get witness names if possible, your partner or others. This protects you legally and helps your agency address the issue. Also, support each other. If your partner was the target of harassment, back them up and corroborate events. These situations can be uncomfortable and even traumatic, so it's important to debrief and inform a supervisor. In summary, with sexually aggressive patients, always have a witness, set clear verbal boundaries, remain professional, don't stoop to banter or anger, and document everything. Your safety and dignity are important, and patients must understand that while we care for them, we demand basic respect in return. Despite our best efforts, sometimes verbal de escalation fails. It's crucial to recognize when it's just not working or when a situation is deteriorating rapidly so you can change tactics to protect everyone. Recognize the signs of failure. If the patient's agitation is only increasing, for example, they go from yelling to actively throwing things or approaching you aggressively, or if they make direct threats like, "I'm going to kill you," and start advancing, these are signs that words alone may no longer suffice. Also, if a patient simply isn't responding to verbal techniques, perhaps due to extreme drug influence or severe psychosis, and is on the verge of harming themselves or others, we have to transition out of de escalation mode into safety management. In such moments, disengage safely if you can. This might mean backing out of the scene. Remember Jason Brooks's advice. If you're being threatened, you need to decide, is it safe for me to stay here? It is absolutely okay to retreat to a safe distance and wait for law enforcement. This is not patient abandonment. You are prioritizing scene safety. You can literally leave equipment behind if it means getting out safely. No piece of equipment is worth your life. Announce to dispatch or others that you're withdrawing until police secure the scene. If you're in an ambulance with a patient who suddenly turns violent while en route, you may need to pull over in a safe area and wait for police if you cannot calm them and they are endangering you, especially if you're the only one in the back. Use that radio. Dispatch, priority, we need law enforcement, patient is combative. Call for backup early. Ideally, you don't wait until someone is swinging at you to radio for help. If verbal efforts are going nowhere and tension is rising, signal for law enforcement assistance or additional EMS crews. Sometimes just more personnel presence can help subdue or calm someone. Some areas have specialized teams, like psychiatric crisis teams or tactical EMS. Use those resources if available for tough situations. If you cannot disengage, say you're trapped or the patient needs immediate intervention to save life and you have no choice, then you move to last resort options, physical or chemical restraints. As protocol allows, you and your team, hopefully with police, may have to physically restrain the patient. Remember techniques like having one rescuer per limb if doing a takedown, etc., and only restrain if you have enough hands to do it safely. An agitated patient who is a danger might need to be fast-acting sedated chemical restraint as directed by medical control, for instance, administration of a benzodiazepine or antipsychotic if in your scope. Those decisions would follow your local protocol and usually involve law enforcement present. It's better to have tried verbal de-escalation first, which is what we're focusing on, because jumping to force can cause injuries and trust issues. But when safety is on the line, don't hesitate to use other measures. As one reference notes, if your patient is combative, attempt verbal de-escalation before using physical or chemical restraints. But if it fails, then use those restraints with proper caution and help. Provider safety equipment like PPE gloves, mask, eyewear is also important if there's a risk of biting or spitting in such scenarios. To conclude this slide, know when to fold them. If you see de escalation isn't working, escalate your response by involving others or retreating. Our prime directive is scene safety. Sometimes the only way to de escalate a situation is to remove yourself and let police handle it. You're never failing by calling for help. You're ensuring everyone gets to go home safe. Let's summarize the key takeaways from today's presentation. First and foremost, safety is number one. Every de escalation technique comes second to ensuring the scene is safe and that you're not putting yourself or your partner in undue danger. Use distance, have backup, and never hesitate to call for help. You can't help the patient if you become a patient yourself. Second, communicate calmly. Verbal de escalation is all about using your words and tone to create calm and chaos. Speak softly, clearly, and non judgmentally. Your approach, hands visible, non threatening posture, and your respectful, steady voice set the stage for cooperation. Third, listen and empathize. So much of de escalation is actually about listening. As we discussed, letting an upset person air their grievances while you genuinely listen can diffuse a lot of anger. People fundamentally want to feel heard and understood. Show them that you do hear them. Nod, use I understand statements. Repeat back their concerns. That alone can take the temperature of the situation down a notch. Show empathy even if the person is being difficult. Often there's fear or pain underneath their behavior. Fourth, your body language and actions matter as much as your words. Keep those hands open and posture relaxed. Acknowledge their feelings without escalating yourself. By staying composed, you invite them to de escalate themselves. Remember the universal non threatening gesture of open palms and maintaining a non aggressive stance. You're signaling safety and empathy with your body, not just your speech. And finally, practice and training improve these skills. Verbal de escalation is truly a skill set that gets better the more you use it. Consider scenarios during training drills. Practice diffusing a mock angry patient or a panicked family member. Some healthcare organizations provide formal de escalation training or crisis intervention team training. Those can be very beneficial. If you find yourself in a tense situation on a real call, debrief afterwards. What worked, what didn't. Learn from each case. Over time, you'll develop an intuition for how to talk someone down. Also, always support your partners and colleagues. If you see a teammate using great de escalation techniques, emulate that. If you see them struggling, jump in to help with a calming presence. Teamwork is huge in these situations. In conclusion, verbal de escalation in EMS can save injuries and even lives. By using calm, empathetic communication, maintaining safety awareness, and knowing when to get backup, you can turn a potentially violent encounter into a cooperative one. You've learned how to handle hostile or violent people, psychiatric crises, intoxicated patients, and domestic disputes with professionalism and tact. Keep these tips in mind on your next call where emotions run high. Staying cool and communicating effectively is just as important as any medical skill we perform. Thank you for your attention, stay safe out there, and remember, a few calm words can prevent 1,000 harsh ones.